So I would like to invite Dr. Shashidhar sir to present, to do a presentation on feeding of preterm. Dr. Shashidhar sir, you can take over. Thank you.
Thank you, Aboli, and thank you, Dr. Srinivas, for inviting me to this webinar. So, as you're all working in the NICU and SNCUs in various government setups, we have already completed the first module, which was on essential newborn care. Now we are moving a step ahead because we want to cater to those questions that you commonly face when you are treating a preterm baby. And the primary question that you would face is how to feed a newborn, how to feed a preterm baby. We have completed the breastfeeding module by Dr. Srinivas Mukhi himself, and we know how to feed a normal term good weight baby. But how to go about a preterm baby is what I'll be trying to answer. If you want to remember one thing out of my next 40 minutes of presentation, that would be this: if the gut is functional, then use it. And also, if you don't use appropriately the gastrointestinal system in the preterm, it can get atrophied. So having said that, I have a few more objectives. That is to describe the appropriate growth for preterm newborns, including use of growth charts, to describe the current practices, current best practices and supplementation of premature newborn, and to understand how to support a breastfeeding preterm newborn. But let me start from the importance of nutrition or importance of feeding a preterm newborn. A preterm baby is born most often in the last trimester or even before. But the last trimester is very crucial for the growth of a fetus. The growth rate in the last trimester of pregnancy is about 15 to 20 gram per kg per day. Between this 24 and 40 weeks of gestation, which is the last trimester, the body weight of a fetus increases sixfold, body length by 20 centimeters, and brain growth, most importantly, by fourfold. And they have a high rate of nutrient accretion, for example, calcium. If you look at the average weight of a reference fetus during this time, you will see that this preterm newborn misses out on everyday growth between 24 and 28 weeks of 16 gram per kg per day, between 28 and 32 weeks of 23 gram per kg per day, and then 30 grams and then 27 grams. So all this can be missed in a preterm baby depending on how much preterm the baby is. So the preterm newborn misses out on a lot of important nutritional factors during this time. Also, the preterm and low birth weight newborn has a unique nutritional needs. They have already a depleted nutrient store. On top of that, they have high growth rates and they are also physiologically immature, which leads to higher requirements than term newborns. This is to replenish their stores, to support their rapid catch-up growth, and to compensate for immature GI functions. But at the same time, they also have a lot of medical problems like RDS, BPD, respiratory, cardiovascular issues, and thereby causing what we now know as extrauterine growth restriction or EUGR, which is seen in approximately even 90% of all those babies who are born extremely low birth weight. EUGR is weight less than 10 centile at 36 weeks of post-menstrual age or a discharge. Why does this happen? This happens because we don't often give credence to nutritional status of a newborn, especially in the first 2 or 3 weeks of life. So a newborn, a preterm one, develops a cumulative calorie deficit starting from day one if the baby is just continued on IV fluids not even given any protein or any fat, this is what will happen. Every day there is an cumulative deficit. And therefore, the NICU weight lags behind the fetal weight. From 24 weeks onwards to 34 weeks, the fetal weight gain is depicted in this dark bar diagram, and the actual NICU weight gain is depicted in the light gray bar diagram. So you can see that the weight gain always lags behind. So what happens when this weight gain lags behind for a significant amount of time is this, which we don't want to see in any newborn baby, especially a preterm newborn whom we have taken care of. This baby can become malnourished. This baby is showing us that nobody has really considered nutrition as an important aspect of care of a preterm baby. We may have been good at RDS management or NEC management. We may have been given antibiotic, we may have treated infection, but if we don't treat nutrition, then we are losing the game, because nutrition is directly related to neurodevelopmental outcomes as well. Even the short-term and long-term outcomes are proportionate to what you achieve in the NICU or SNCU. Every 1 gram per kg per day of added protein up to 4 grams can increase the mean developmental index, sorry about that, mean developmental index, that is IQ, by 8 points. And every 10 kilocalories can increase the mean developmental index by 4.6 points. So the better the nutrition status, especially in the first 1 month, the better the neurodevelopmental outcome at 18 months of age. So if you see these two bar diagrams, a neurodevelopmental impairment, if you have just 12 gram per kg per day, is about 50 to 60%. But if you achieve 21 or 20 gram per kg per day, the amount of neurodevelopmental disability that you're going to have is reduced drastically in this. And similarly for cerebral palsy, if you achieve good weight gains of 15 to 20 gram per kg per day, the number and the incidence of cerebral palsy can be reduced by just giving good, adequate nutrition for these babies. So what are the determinants of nutrition? Most of our babies are already nutritionally compromised in utero as a fetus. They also have poor growth and nutrition. On top of that, they are born preterm. So at current status, when they come to our SNCUs, they have increased losses and also increased needs. And they have poor GI function, which we have already discussed. And this nutritional status implicates weight gain, NEC, and even respiratory function at the short term. In medium term, it can affect growth and neurodevelopment, like we have discussed. And in the long term, it can affect cognition, IQ, also cardiovascular health and type 2 diabetes. So nutrition plays a central role in management of a preterm newborn. So how do you go about feeding this preterm newborn? That depends entirely on physiology and maturation. We know that some of the reflexes take time to develop in a preterm newborn, and our mode of feeding is entirely dependent on this maturation. For example, a nutritive suck develops somewhere around 29 to 30 weeks, matures and becomes a good sucking reflex by 32 weeks. And the fetus can coordinate his swallow and breathing, suck, swallow and breathing by about 34 weeks. So more on this when we go on to how and why to give a particular type of feeding for a newborn baby. Just keep that in mind. We also should know the concept of corrected age or post-menstrual age. We tend to give a benefit of doubt for those babies who are born preterm. So baby is born at 32 weeks, then we say he's 8 weeks preterm, and we continue to follow his post-menstrual age or corrected age up to 2 years. So any baby who is born preterm needs to be assessed for growth, nutrition, feeding, and development only by corrected age. So if the baby who's born at 32 weeks is now actually 2 months chronological age, that baby will be just 40 weeks or 0 days as per growth and nutritional needs and also development. So when we have to assess growth, it is imperative to use a growth monitoring tool. Firstly, we need to be measuring weight for all our babies every day. What we will see is that the baby loses about 7 to 10% of weight in the initial few days, and any preterm baby has to regain its birth weight latest by 14 days of life. And when we measure the weight, we need to make sure after this initial period of weight loss and regaining birth weight, that every day baby has to gain about 15 to 20 gram per kg per day. Every week, the length should increase by 1 centimeter. Every week, the head circumference should increase by 0.7 to 1 centimeter. So that is our target. So how do you know whether we are on target or not is by using growth charts. For example, these are Fenton's growth charts. You can use any growth chart, postnatal growth chart, but these are the ones which are commonly used. For Fenton growth chart, you have a boy and a girl separate growth charts. You plot the weight, head circumference, and length at least every week. Though you are measuring the weight every day, head circumference and length every week, and then you see longitudinally what happens to this baby's growth. If you plot, you will get something like this. If you get a smooth curve which is following the baby's own curve in the fetal life and it's continued, then probably you're on the right track. If you see plateauing, or if you see a dip, or if you see crossing of centiles, then that is not correct, and maybe you have to take corrective steps of improving nutrition. So please use growth charts. Only when you use growth charts, you will get to know whether these preterm babies are catching up or not. It's a debate whether or not you actually need a catch-up growth, but definitely you need a healthy catch-up growth. If you don't catch up, if you are a preterm baby, you don't catch up to your term peers, as we already discussed, it's going to have poor cognitive and neurodevelopmental outcomes, and prolonged growth restriction. Babies are going to be small for a long time, and they are also going to have organ dysfunction. But if you catch up too rapidly, say by giving formula feeds, what is going to happen is you're going to develop a lot of other morbidities like metabolic syndrome because of altered fat distribution, obesity, diabetes, and cardiovascular disease as you age, about second or third decade of your life. So you need to achieve a balance of catch-up growth. We have to set a target for any preterm baby that comes to our SNCU. That is, you have to achieve a full feeding by about 150 to 180 ml per kg per day. If you are ELBW, that is less than 1 kg, then by 2 weeks, you have to achieve that full feed. If you're between 1000 to 1500 grams, you have to achieve full feeds by 1 week. This should be our target. How to go on achieving this target is by starting early and advancing faster. In babies who are less than 1 kg, we can start feeding by 15 to 20 ml per kg per day even on day 1, and increase by 15 to 20 ml per kg per day every day. So you need to actually calculate that this baby received such a volume, say 20 ml per kg per day today. So tomorrow this baby should receive additionally 20 ml. So baby has to receive a 40 ml per kg per day on the second day of feeds. If the baby is more than 1 kg but less than 1.5, then you can start even at higher volumes, 30 ml per kg per day, and increase by 30 ml per kg per day every day. And any baby who is more than 1.5 kg should be directly on full feeds. And as I speak, I know that these are arbitrary numbers, so I'm just trying to give you a round off figure of what to do for each weight. And even NNF CPG latest recommendation says feed volumes can be increased by 30 to 40 ml per kg in stable VLBW newborns who don't have feed intolerance. We all know, and most of your SNCUs will have this table of fluid requirements of more than 1.5 and 1 to 1.5 based on the day of life. And this fluid requirement is equal, it can be used even for feed requirement as well. How frequently should we feed? If the baby is more than 1.25 kg at birth, you can feed every even 3 hours. It's allowed to feed every 3 hours. If you have less nurses in your SNCU and you have more number of babies who are more than 1.25, you don't have time to feed all of them on time. It's better to make a feeding schedule of 3 hourly, and there is no difference between 2 hourly feeds. But if the baby is less than 1.25, you need to feed them every 2 hourly. And after feeding a baby, most of you could notice gastroesophageal reflux. So to avoid that, feeds are best tolerated if you have time and resources. Always try to put the baby in left lateral position immediately after feed and then over to prone position. You can also elevate the head to prevent reflux. I said you need to start feeding as early as possible, but there are few exceptions. The first exceptions are if the baby is less than 1.2 or less than 30 weeks, you can still start trophic feeding or minimal enteral nutrition. What is a trophic feeding? I'll come to in a while. And once stable, you can increase by 20 ml per kg per day to reach full feeds. Secondly, you may have babies who are in shock requiring inotropes. You may have respiratory failure requiring ventilation, asphyxia, seizures. In those babies, also you can feed, especially if you're on resolving RDS, resolving shock, and stable asphyxia, no active ongoing seizures. At that time, you can start feeding. And when you start feeding, you can increase faster if you're 1.5 kg or more, and slower about 20 ml per kg, as I discussed in the last slide, if you are less than 1.5 kg. Also, you may find that baby has bilious vomiting or bloody vomiting. You can start as soon as this condition stabilizes, or if there are surgical condition, you have to wait till the surgical condition resolves. In any case, once the baby reaches about 100 to 120 ml per kg per day of feeds, you can stop IV fluids. Why I'm saying that is giving IV fluids for a long time increases risk of peripheral line acquired bloodstream infection, also sepsis, etc. So try to remove your IV lines and IV fluids as soon as possible. That should be our goal. Just a few slides about trophic feeds. Trophic feeds are feeds which are given just to keep the gut going, to help the gut to mature. That is about 15 to 20 ml per kg per day. You have to start within 6 hours. All of this asphyxia, distress, hypotension are not contraindication for trophic feeding. The only contraindication is when you have an intestinal obstruction. How does it help? It increases hormones. It can lead to less feed intolerance, more weight gain, more calcium phosphorus retention, less days on TPM. It decreases the time that you take to reach full feeds and also decreases your hospital stay by 1.5 days. So if the baby is not on full feeding, you have to start at least with trophic feeding as soon as you can, especially within 6 hours of life. So coming to choice of milk, what feeding should I give a preterm newborn was a question about 5 to 6 years ago. But now it is convincingly answered that the first choice is mother's own milk. Second choice is pasteurized donor milk if you are lucky enough to have a milk bank. The third choice, least preferred, is preterm formula. So MOM is highly recommended for even a preterm low birth weight newborn. But why is it recommended? Is because even for a preterm newborn, there are a lot of benefits of feeding breast milk, like reduced sepsis and NEC compared to those who are on formula feeds, reduced hospital readmissions, reduced ROP and BPD, and you can advance feeding faster, thereby leading to reduced hospital stay. But more significantly, those babies who are fed mother's milk, if you take at 18 to 30 months also, they have higher IQ points, mental, motor, and behavior wise. And they have lower incidence of metabolic syndrome like diabetes, hypertension. So the first choice always should be mother's own milk. A mother's own milk starts with colostrum. and oropharyngeal swabbing of colostrum. If the baby is not getting anything to the GI, at least you have to coat the oral mucosa every 3 to 4 hours. So whatever little colostrum you get, which is high in immunoglobulins, cytokines, which prevents all the harmful bacteria colonization, even if the baby is on ventilator, CPAP, just take a few drops of colostrum and apply to the mouth. And this can help in many ways, like granting immune benefits to infants, and definitely it's not harmful. So if you have these babies, what to do? Weight less than 1.2, gestation less than 30 weeks. You have to start with intravenous fluid, you have no other go, but always start trophic feeds. You aim to, then whenever baby is tolerating it well, increase faster, aim to reach full feeding by 2 weeks. And once the baby crosses about 30 to 32 weeks, you start with oral feeding, which is more physiological than NG feeding or gavage feeding. Later, when the baby grows to 34 weeks, start with breastfeeding. Baby weight between 1.2 to 1.8, gestation 30 to 34 weeks. Initially, you need not start all these babies on IV fluids. Start with NG or OG feeding, intragastric feeding, then progress to calorie spoon or paladai feeding, and shift to breastfeeding as soon as the baby is able to suck. That's by about 34 weeks. Only if the baby is sick, you need to give IV fluids. More than 1.8, more than 34, the first choice always is direct breastfeeding. In addition, you may have to give a little bit of paladai or calorie spoon feeding. I'm sure most of you would be knowing what I'm talking about, what is gavage, what is calorie spoon or paladai feeding, and may be called in different names in your local languages. So we need to do a stepwise approach to feeding readiness. Intragastric tube feeding, if accepting and ready, put on paladai or oral feeding, and if accepting ready, sucks effectively, go on to breastfeeding directly. But having said that, breast milk is the best choice. We need to know we are talking about preterm babies here, and there are some limitations for a preterm baby with breast milk only. The first limitation, which we are going to talk about in a little more detail, is inadequate milk supply. That you need to give so much milk, but mother is not able to give you that much milk. That may be because mother is herself ill or stressed. She may be difficult to maintain because baby is not sucking at the breast. The mammary gland itself is immature. She has delivered a premature baby. The mammary gland is not mature enough because it also matures during the 3rd trimester. And you may have delayed the initiation of expression of milk. Also, even if you have volume of mother's milk, there may be feeding difficulty in the baby, like reflux, feed intolerance. And there may be comorbidities like BPD or PDA, which you need to restrict the volume of fluids. Also, the breast milk itself may have lesser nutrient content compared to what is expected for a fetus. So, taking the last point first, for a preterm milk, it does not satisfy all the requirements for a growing preterm newborn. This is if 100% is what is required. It gives about 76% of protein. This is in general for all populations, smoothed. Sodium of 68, calcium of just 32%, half the requirement of phosphorus, iron requirement, it doesn't meet at all. Zinc requirement meets about half, and vitamin A, it meets about 38%. So this is the reason why we need to give something in addition to breast milk. When I say something in addition, I mean supplements. Supplements like iron and vitamin D, you can start as soon as 2 weeks, even earlier if the baby reaches full feeds earlier, and you need to continue till about 1 year of age. Iron, the starting dose varies from 2 mg per kg per day to 4 mg per kg per day. Vitamin D also starting dose varies from 400, you can go up to 1000 international units per kg per day. If the baby's weight is less than 1.5, then you also need to give multivitamins and calcium and phosphorus. Multivitamins, you get a lot of multivitamin drops, especially look at the dose of vitamin A, which is most important, and look at that zinc is provided in those vitamin drops, and titrate drops based on them. The usual dose is 0.3 ml BD. Calcium and phosphorus, calcium is needed about 120 to 140, can go up to 200 as well. Phosphorus 60 to 90 mg per kg per day. On reaching full feeds, continue up to 3 months or 3 kg, whichever is later. But you are still not meeting the calorie requirement and by protein requirement. So for that, you may need to give something called human milk fortifier, which is a multi-component fortifier made of bovine milk, and you add to the human milk and give the baby orally or through NG feeding. So the NNF recommendation says for any baby less than 1.8 receiving at least 50 to 80 ml per kg of enteral feeding, you need to start this human milk fortifier. But considering you are working in SNCUs and in resource limited settings, you may not get this so easily. So if you have a baby who's not gaining weight, even on full enteral feeding 150, 180 per kg, then you need to add this human milk fortifier to compensate for calorie and protein deficit. The first point which I mentioned was the problem with breastfeeding is that you don't have enough supply of milk from this mother who was given birth to a preterm newborn. So how can we increase? What can we do? There are a lot of QI studies being done to improve mother's milk availability. The first thing what you should know that she is already stressed because her baby is sick and in the SNCU or NICU. So you need to support her psychologically. Mother has to probably stay in NICU as long as the baby is there, just to encourage her feeding, encourage KMC, and encourage her visits to NICU. The longer you do KMC, probably the more milk you will get. Always start expressing milk from day one of life, even though she may be just recovering from anesthesia from cesarean. She needs to express milk, and that is the only way to get adequate volume when you actually need it. She also needs to take adequate rest and nutrition. There is a role of domperidone to increase preterm milk, but that role is at the end when you have exhausted all the options. Also, if there are other preterm mothers, always hook one onto them and make sure that she helps this new mother to improve her own milk. For pumping in the first 2 to 3 weeks, you can use hand expression or electric pump, or you can do double electric pump. But the crucial thing is that you need to empty each breast so that you express both hind milk as well as fore milk in each expression. And this milk needs to be frequent, as in 2 to 3 hours a day and at least once in the night. And the duration should not exceed 4 hours in between 2 pumpings. So she needs to pump at least 7 to 10 times in 24 hours to establish milk supply. After 3 weeks, the frequency can be little low. That is about 4 hours, every 4 hours a day if she's getting adequate volume, and at least once in the night. So at least try to pump 60 to 80, 6 to 8 times in 24 hours, either with hand or breast milk pump expression. How do you know this baby is getting adequate feeding or adequate nutrition? For spoon or paladai, you need to see that there is good swallowing, not without much coughing or spilling of milk, and baby accept the required amount. If the baby is on direct feeding, you need to know that whether the baby is latching well and able to suck effectively and long enough. In all modes, you need to see that baby is gaining adequately, that is 15 to 20 gram per kg per day, at least passing urine about 6 to 8 times. There is a small bugbear of a feed intolerance. That is, babies may not tolerate feeds. I don't know why, but it is called feed tolerance. How do you go about this looking for feed tolerance? The idea of pre-feed aspirate or measuring abdominal girth every 2 hourly and then you decide to give that feed is obsolete. You should not be doing routine pre-feed aspiration. What you instead need to do is just inspect the baby before each feed visually and and if there is a visual distension, then only aspirate the abdomen contents. The aspiration is not significant as long as it is blood or bile stain. In that case, withhold feeds for 1 or 2 days and then restart. If the volume is clear, but it is more than 5 ml or more than 50% of the feed, then you need to withhold only 1 or 2 feeds. But to emphasize, if there are no other signs of feed intolerance or NEC or systemic signs, routine pre-feed aspiration is not recommended. So finally, the take-home messages of my talk are: nutrition dictates survival and both short and long-term outcome. Early initiation with rapid advancement is safe and well tolerated. For preterm newborn, also mom is the best choice. Routine pre-feed aspiration is not recommended, and route of feeding is based on maturation of these reflexes. Sometimes you may need to give micronutrient supplementation, especially LPW newborns, and also fortification if you're not achieving enough growth. And always make it a habit to weigh the baby every day and plot, and measure the length and circumference every week and plot on a chart to make sure you are on the right track. Thank you. Now I hand over to Aboli.